What does it say? Low network connection. Are you on Wi-Fi? I'll take it off. Hold on, guys.
That's funny.
What? I'm gonna refresh it, okay?
I feel like you're looking at it like it's supposed to. It's supposed to give you an answer or something.
There you go. You see? Dr. Neville tagged you in a post. At the time.
Hi, everybody. Giving everybody a few minutes to
log in.
Log in.
And while I share, I'm going to share my video so I can have a chance of winning a Michael Kors watch. Just kidding. I don't qualify. Okay, so
tonight's live Facebook is sponsored by Altoids. She actually had a question: is does bad breath mess up going out and having sex?
I don't know.
Of course it does. Like,
okay, so you guys, oh, do you usually share it too? You sure?
no, they can sign on. I mean, you can go ahead and do it if you. They can always deny.
Hold on, you guys. We just gotta share the video too. If you said, don't you usually do it though?
No, I haven't. But go ahead. They'll say yes or no.
Okay. 1 second. How do you get to drneville.com?
You go to home.
Can I just share it from here?
I think so. Yeah.
Oh no, I don't think so. Hi everyone. So share the video. We'll put you into a drawing to win a beautiful Michael Kors watch. I'll show it to you in just a little bit. I don't know how you where to share it. I'm gonna share it like directly to your page. Let me see. Sorry guys, 1 second. So you can go over topics of what we're discussing tonight.
Okay. So we'll go ahead and start. I've gotten a lot of questions, and there's so many questions because the last presentation we had over 14,000 views, and of course you can imagine there's hundreds of requests for information. So the main things that I want to talk about today were something that I found out about related to ACOG, which is the American College of Obstetricians and Gynecologists. Now, you have to understand that ACOG is the largest organization of board-certified OBGYNs in the United States. They are not only the largest, but the most influential as far as what gets passed or considered to be the standard of care, as well as the lobbying portion of ACOG, which is right out of Washington, has an incredible amount of influence when it can influence on Congress in general. So, and also with the FDA. So if ACOG doesn't like something, it does put a lot of pressure on the FDA as well as on Congress to consider their position. And many times, because we consider ACOG to be the expert organization, we do go with their recommendations. Although I'm not a member of ACOG for a variety of reasons, I do read their bulletins. I do read all of the information they provide, and I take it as a learning source or a standard of care source. So what bothered me was something that I found out about related to ACOG was that they came out with a frequently asked questions basically it's a bulletin for its members. And what that frequently asked questions stated was that talked about the Essure device, but didn't describe it as Essure. They described it as hysteroscopic sterilization, just like the FDA does. The issue with that I have a real problem with is that there's only one device in the United States, and actually in the world now, that actually is hysteroscopic sterilization, and that is the Essure device. So I always had an issue with them not just describing it as Essure. But anyway, that's semantics. Here we talk about hysteroscopic sterilization. So just a little bit of background. In March of, in 2015, there was a committee meeting at the Food and Drug Administration to go over the complaints that over 10,000 complaints at the time. I think it was closer to 16,000 complaints at the time related to the Essure device. And what the FDA did is commenced a meeting of specialists in the Department of OBGYN, including specialists from other fields, and they commenced a meeting to discuss the issues or concerns related to the Essure device. And out of that meeting came recommendations, and from those recommendations came a change and in the can you turn it on?
Yes, I'm going.
From out of that came recommendations to the FDA and to Bayer, and they shot it back and forth, and finally they came up with a change in the labeling for Essure, and that happened in 2016. And I wanted to just give you a moment here, and this is just one something that I got off the internet related from CNN that stated on March the 1st of 2016 that the Food and Drug Administration said that it will require a black box warning for Essure, an implantable permanent contraceptive device. A black box warning in the labeling of products is designed to call attention to serious or life-threatening risks, according to the FDA website. So the FDA and Bayer agreed to change the labeling of the Essure device in 2016, requiring that the label state the risks are related to the Essure device. And also, the black box warning included, along with the requirements, a checklist for patients to be advised of those particular issues or concerns. And this is what happened, which we knew was going to happen. Because it was a guidance only, the vast majority of OBGYN doctors that knew anything about Essure, that were still placing Essure, totally ignored it. And we knew that was going to happen because we've seen that happen with other issues with black box warnings and other devices such as medications such as Cipro, the Mirena IUD, Depo-Provera injectables, the vaginal meshes. So we knew that it would probably be ignored by a significant number of doctors. What I didn't know at the time is the fact that ACOG disagreed with even changing any of the labeling. It has a position where we are smarter than FDA. We are smarter than the company that created the device. We should have a right to talk to our patients the way we want to talk to them and advise them in the manner that we want to advise them. And forget about FDA, forget about the Bayer Corporation. We know better because they're our patients. And that the audacity of that particular train of thought, is exactly what ended up hurting women. Because since ACOG didn't make a stand on it and didn't support the FDA recommendations or the Bayer recommendations, it ignored the black box warning in most, if not all, of its information that it gave out to its fellows. So here is an organization that's supposed to protect women, and what it really did is ignore the most obvious and most important thing of Essure at the time, which was that it had been stamped with a black box warning. So how long did this go on? Well, the guidelines changed in March 2016 to November 2016. After that, November 2016, it was pretty much set in stone that the guidelines were there for everyone to be aware of, whether or not the doctors put in the Essure directly or whether or not they were doctors in other specialties. The information was already put out there and accepted by FDA and by Bayer. So it surprised me when in April of 2017, ACOG came out with frequently asked questions related to hysteroscopic sterilization. Remember, hysteroscopic sterilization is Essure. So basically, this information is wrong, it's antiquated, and it basically gives the wrong guidelines for doctors to follow. It talks about information that was presented in the original studies. It talks about a failure rate of only 1 in 1,000 over a 5-year period of time, which wasn't information in the original studies. But it doesn't talk about anything related to the black box warning. So when a fellow were to read this information and it said, oh, there's nothing really wrong with hysteroscopic sterilization because I read it from ACOG. ACOG gave me the information. So I don't know what you guys are talking about with this black box warning. Obviously, it's a bunch of crap from the internet. It's obviously not important enough for me to even do any research, and therefore I'm not going to advise my patients on it. And that is the cascade of ignorance and the audacity that went on related to this problem. And this was a concerted effort. You do not present guidelines or frequently asked questions on a product 1 year after the FDA comes out with a black box warning and it not be an obvious attempt to ignore what the FDA and what Bayer had already stated needed to be acknowledged. So now this was in 2017. Now we're in 2018. And on April the 9th, the FDA notified Bayer that it was accepting their changes in the labeling, where now, rather than be guidelines related to the black box warning and patient checklist, that it was now mandatory. And they made it very specific. Very specific. There are 4 points here, and the 4 points basically state that the information is available to you. You must give that information to doctors that are placing the Essure device. The doctors that are placing Essure device must give a checklist to their patients for review. The patient must sign the checklist, and then the doctor must sign the checklist as well before the device is placed in the patient, stating the following, that they acknowledge the risks and the benefits, indications and alternatives to the patient prior to the placement of Essure. So now this is mandated. But you know what? ACOG is still ignoring that. Even though it's mandated, ACOG has not come out with any information and basically came out with a letter stating that we disagree with the Food and Drug Administration, we disagree with Bayer, that it's up to us still to allow us the opportunity to speak about what we feel Essure is to our patients and not let the FDA or Bayer meddle in that patient-physician relationship. You know, that's a bunch of crap, okay? Why? Because you're not doing it for the right reasons. You're not acknowledging anything in the black box warning. More than 2 years of information and study went into changing these guidelines. And it's like pulling teeth to get guidelines or labeling changed with the FDA. So when it was changed, this is rock solid information, okay? And ACOG, you may not agree with what the black box warning says, but you be damned if you're not supposed to talk to your patients about it. That is what FDA mandates. That is what Bayer is saying has to happen. And you, by not discussing it with your patients, are violating the standard of care, are completely unprofessional and unethical. So for all of the doctors out there and for ACOG, because you're representing your doctors, for all of you doctors out there that are continuing to ignore the mandated black box warning, and your patient ends up finds out about it and it did not sign the patient checklist, why don't you just write the check? Because you're going to need to pay out of pocket for violation of the standard of care, violation of informed consent, and if it was done intentionally, willful negligence on the part of the doctor, which many insurance companies will not cover for. Because if you're doing something to intentionally hide information from a patient, then that's willful negligence. And malpractice insurance doesn't generally cover stuff like that. So that's going to be an out-of-pocket thing. So for all you ladies, I want you to go to the websites of all your doctors, any doctor that claims that they're still placing Essure, and look there and see if they've talked about the black box warning on their website, because the Food and Drug Administration says for any advertising that's being done related to Essure, you need to talk about the black box warning. So if that's not what's happening, your doctors are really not informing you properly. They're advertising improperly. Deceptive is a strong word, but it may apply in this circumstance. So take the time to go on your websites, find your favorite doctor, and if that doctor is advertising about Essure, find out whether or not they're talking about the black box warning online, because they may say something in the office. And here's another one for you. Here's a kicker, ladies and gentlemen. Please get a copy of every single thing that you ever do in a doctor's office. A copy of every operative report, every note. Get copies of everything. Because if something goes wrong, those papers miraculously start disappearing. And your doctor does not have to hold on to your medical records for longer than 7 years. So if you wind up having a problem, you're going to be surprised at how many pieces of paper end up disappearing out of the doctor's office. Now, it's less likely to occur in the hospital, but still, it can occur. So get a copy of every document that you ever have related to your health, and make your own little file that you keep at home. So that was my little discussion related to ACOG for today. And take-home message, be your own patient advocate. Make sure that your doctors are being just as well educated as you are related to the problems of the black box warning. And this crosses all specialties because, like I said, most of the time in the middle of the night, you're not going to be seeing your GYN doctor. You're going to be seeing the ER doctor, and they need to be just as well educated about all these problems as your OBGYN is. So we'll take a few minutes. You want to talk about sharing and...
Oh, this is the watch. But, so shiny. So I shared the video like 3 times.
Sure.
So I have 3 chances to win.
Sure.
Just kidding.
So share the video and please comment.
But just a warning ahead, we will be talking about...
the next subject.
Yes, just in case you have kids around.
Yes, the next subject's going to be...
This is very adult-like.
The next subject will be rated R. We're using drawings rather than actual pictures because it is rated R. I'd rather be rated R than rated X. But we get a lot of questions from patients related to when is it okay to have sex after a procedure, whether or not it be a tubal ligation or vaginal mesh placement,
or after Essure,
or after Essure, after hysterectomy. And so these are important questions, and each particular procedure has a certain amount of time that's recommended before you go ahead and have intercourse. And the most common, the basic recommendation is for after a vaginal delivery, for example, the recommendation is 6 weeks before having intercourse. The same thing applies to cesarean sections. As far as tubal ligations are concerned, if they're done laparoscopically, then you generally only have to wait about a week to 2 weeks. Again, talk with your doctor about this to make sure that that's what they recommend. But a week to 2 weeks is not unusual. If you're talking about vaginal mesh placement, that takes a long time. You're looking at 6 to 12 weeks sometimes before you can have intercourse after a vaginal mesh is placed. And after hysterectomies. Hysterectomies are most important for those women that need them for other reasons, such as uterine fibroids or endometriosis. But we're talking about, we're focusing in right now on the women that suffer from Essure complications and require either a subtotal hysterectomy or a total hysterectomy. And there is a confusion as to what the differences between them are. And long story short, in medical terminology, for every part of a procedure that you do, there's actually a little bit of a description related to it. So if you have a hysterectomy done vaginally, but you're using cameras, then you're talking about a laparoscopic assisted vaginal hysterectomy. If you add the removal of the fallopian tubes, then it's laparoscopic assisted vaginal hysterectomy, bilateral salpingectomy. And if you remove the ovaries, it's laparoscopic assisted vaginal hysterectomy, bilateral salpingectomy, oophorectomy. Now, most people do not want to remember or cannot remember all of those words. And so basically, in layperson's terminology, a woman that has had a partial hysterectomy is that she's had her uterus and her tubes out, but she's kept her ovaries. And a total hysterectomy is when a woman has had everything removed, including her ovaries. Now, that's a bit of a misconception, but that's some of the terminology.
Are you willing to take a few questions?
Sure.
Crystal Rosales, I have a random question. I had my tubes tied about 2 months after I had my son, and I was told to go back for a sonogram after 3 months to see if the surgery went well. So 2 days before I went to my doctor, I get a call and was told that they didn't take the women's health program, that they had to cancel my appointment. So I haven't been able to get that done. I have asked them if they can give me options of where I can go. She said no, she didn't know where I could go to get myself checked. What can I do if I don't have the money to get it done? Do you have any suggestions of where I can go?
Okay, this is one of the most common problems. I'm not solely talking about Essure, but it does ring a very important point. For women that have had Essure placed, and specifically for women that have had temporary Medicaid, this is what's been happening. The doctor, whether or not they know or don't know, but they should know what type of insurance the patient has. If the patient has had temporary Medicaid, those doctors should know that that patient will need hysterosalpingography or an HSG test done 3 months after the procedure is done. It falls below the standard of care for a doctor to place the Essure device, knowing that that patient is not going to be able to have the confirmatory test 3 months later. And that's happened to thousands of women that have had temporary insurance, temporary Medicaid for a pregnancy, and have been either convinced or basically given no other choice but to have the Essure device placed. So most of the time you can go through your primary care doctor and request that either an ultrasound be done or the HSG test be done. And for a tubal ligation, outright, a tubal ligation, it's not necessary to have either a sonogram done or a HSG test done. But when you're talking about Essure, it's actually mandatory as a confirmatory test to make sure that the coils are in the right place. So I would suggest that you speak to your primary care physician and then start shopping around to the different radiology centers. There are standalone radiology centers, and you can explain your situation and ask them if they'll give you a patient discount.
Texas Tech or UMC.
Here in El Paso.
If you're local here in El Paso, Texas Tech or UMC are very good at accepting patients with no insurance who need. I think they even will put you on their insurance plan, which is called, I think, Healthcare Options. And everything has to be done through them, whether through Texas Tech or University, but they can cover all your medical expenses.
Yeah. So locally, talk to Texas Tech or UMC and try to get on Healthcare Options, which is a sliding scale system. Don't accept no for an answer. Your doctor should have properly informed you as to what the mandatory requirements were. And basically, a lot of doctors have been washing their hands after they place the Essure and saying that's your problem, to whether or not you're going to get the confirmatory test done in 3 months. And that is, again, unethical, unprofessional, and as far as I'm concerned, below the standard of care.
Okay, so Camille Martinez Cifuentes, my doctor recently retired. I've called the old office many times, and I can't get a copy of any of my records. What should I do? The
records by law are supposed to be held for 7 years. So even though your doctor has retired, that doctor could still be could be sanctioned if he still holds on to his license by the state at which licensed him. If most practices will either be required to keep those medical records for the 7 years, or they will give those medical records to someone else to hold for them. So if you can't get any help, talk to your state medical board and ask them what options are available, since you can't get a hold of your medical records, and those doctors, even though they're retired, are still supposed to hold on to those records or give them for safekeeping to someone that does.
Usually when they retire, they're supposed to let all their patients know, either by email or sending out a letter, that they're retiring records. And please come pick up your records. So, Alicia Miller-Riggs, the doctor who placed my Essure and removed it, is no longer an OBGYN, and I can't find my records. So I guess that would apply for the same question we just answered right now on if you're having difficulties finding records or records may have been misplaced. It'd be the same.
The hardest ones to get a hold of are going to be when the procedure was done in the office. If the procedure was done in the office, it's very difficult. It's harder. But if the procedure was done in a hospital, you can go directly to the hospital and ask for your medical records.
Christina, I've had a laparoscopic bilateral salpingectomy 29 weeks ago. I'm guessing she put 29 weeks ago, and still have a lot of discomfort. Is that normal?
No, generally, was it? Read the question again. I'm sorry.
I've had a laparoscopic bilateral salpingectomy. She put 29, so 29 weeks ago, and still having a lot of discomfort. Is that normal?
Okay, that's not normal, but here is where we run into an issue. A lot of us OBGYNs are removing the fallopian tubes completely now, the salpingectomies. And the reason for that is, for one theory, is that some cases of ovarian cancer originate in the fimbriated ends or the terminal ends of the fallopian tubes, which generally cover the ovaries. So we started suggesting that we remove the entire fallopian tube as a form of lowering the risk of ovarian cancer in a certain subset of women. The problem with that is that that's a great idea, but a lot of us started doing it simply because it pays more money. Okay, it adds about 10 minutes to the surgery, but we get paid a lot more money to remove the entire fallopian tube rather than cut or burn them. So it was a money-making machine kind of thing going on there too. And if you remove the entire fallopian tube, and you can end up as all the way to the where the uterus is in the coronal region. Some women have started complaining of symptoms of pain related to the removal of the fallopian tube. So I would suggest that you get another evaluation, possibly an ultrasound, to see if there's anything going on with a fragment, or a portion of the fallopian tube that still was left behind that may be enlarged. A hydrosalpinx, for example, that's what it's called, an enlargement of the fallopian tube stumps, and see if that can explain part of your problem.
Christy Uribe, is there a way I can get Essure removed, and would any insurance cover it? I haven't found any doctor that wants to remove it.
Okay, this is where it gets interesting in my point of view. For a significant number of women that have complaints, chronic pelvic pain, irregular bleeding, dysfunctional uterine bleeding, pain with intercourse, these women who go to see their GYN doctors are generally able to get a hysterectomy or another procedure done simply because they have those symptoms. But when the doctor finds out that you have Essure in place, they don't want to touch you. They don't want to help you. But if it was for any other reason, they would do the hysterectomy. So I don't understand what's going on there in their thinking. But basically, they feel that Essure is a complicated or would complicate the procedure, and therefore they don't want to do that. There are doctors within the Essure Problems Forum that you can find in almost every state. There are some great doctors in across the United States. Dr. Sills.
Well, here locally. I'm not sure if she's here locally.
Okay, locally for those patients that suffer from problems with Essure, we give free consultations if you don't have insurance. So if you need help locally, we'll be glad to help you. In removing it by doing a hysterectomy, it's approximately $6,000, including the hospital fee, our fee, and the labs, all of the pre-op workups and the follow-ups. That's significantly lower as compared to some other parts of the United States. If you're looking in California, for example, on the West Coast, Dr. Eric Sills is a specialist. In Austin, Texas, you'll find Dr. Sean Tassone. In North Carolina, it's Dr. Charles Monteith. In Florida, is Dr. Steve McCarris. In New Jersey, are the doctors Pelosi. Marcos Pelosi is the senior and the junior. But check out Essure Problems Forum. Maybe they can help you in your area.
I think they have a list of certain doctors. Mirtha, where are you located? We're located in El Paso, Texas. Stephanie Harrington, I had Essure and Novasure done together by my OBGYN in November of 2017. Starting 4 months ago, I started having extreme right side pelvic pain. I have seen my doctor every month when it happens. She believes it's endometriosis and is not from, I guess, familiar, or is not from Essure because it's, if it's not, that it's not from Essure because only happens when I'm on my period. She wants me to have a Lupron injections for 6 months before we talk about a hysterectomy. Should I see someone else for a second opinion?
Yes. Number one, your doctor should have never done the ablation and the Essure at the same time. That's specifically contraindicated in the listing and labeling of the product. Again, your doctor should not have done the ablation and the Essure at the same time. It's contraindicated per the labeling related to the particular combined procedures. With that said, the reason why it's not to be done at the same time is because you cannot confirm during the hysterosalpingography 3 months later when you've done an ablation. Now, what the ablation does is it burns the inside lining of the uterine wall. Therefore, the two sides of the uterine wall where you would normally bleed from fuse together and produce areas called synechii. These synechii do not allow fluid to come in and out of the uterus any longer, and therefore you cannot confirm that the coils are in the right place, properly placed inside of the fallopian tubes. And so, if you can't do the HSG test, or it makes it more difficult to do the ultrasound, which is not as good as the HSG test, then you should have never done the procedure to begin with, and that's the ablation. Next. The ablation significantly increases if it touches the coil, significantly increases the risk that the coil will become damaged. If the coil becomes damaged or it's put in the wrong place to begin with, you could have significant scarring, significant inflammation, significant pain following the procedure. Third point, there is a condition known as post-ablation tubal ligation syndrome. Post-ablation tubal ligation syndrome occurs when you have ablated the tissue inside of the uterine wall, but there are little areas, especially close to the fallopian tube, where there's a little space, and in those little spaces, fluid starts to build up. Endometrial tissue grows, and it causes pressure along the fallopian tube and the uterus. So, that increases your risk of adenomyosis, which is similar to endometriosis. And so in your particular situation, I would say that would the use of Lupron harm you? No, it may actually make you feel better. But the use of the Lupron may not actually be treating endometriosis. It might be treating post-ablation tubal ligation syndrome. So in the end, you would still need to have a hysterectomy. So my recommendation is, because there was an error made to begin with, that you should push for a hysterectomy. And if you go to the online Essure.com, you can find the labeling that specifically says that you are not supposed to do an ablation and an Essure at the same time. And with that, find yourself another doctor.
Priscilla Vargas, I'm looking into getting Essure, however, only seeing negatives. Should I really think getting it?
Okay.
About getting it.
Mm-hmm. Okay. My point, and I know that this is my opinion, is that I don't believe that any woman should have Essure except for a very small group of women that cannot undergo general anesthesia. Okay. But that's a very, very small number of women. What the problem is that Essure seems to work okay for about 70% of women, but is catastrophic in up to 30% of women. Do you want to be in the 30% group where it is catastrophic for you, and 5 years, 10 years from now, you end up having a problem that you were warned about, you didn't think was going to happen, but then it becomes a serious issue to try to fix? This is the reason why I say 7 out of 10 times is not good enough for me. Would I stick my hand in a light socket, or would I play Russian roulette? 7 out of 10 times I would be okay. 3 times out of 10 I'd put a bullet in my head. That's my opinion.
Rachel Bell, can you get pregnant with this product? And if you're speaking about Essure, then go ahead.
Originally, in the original studies, because they were so small, and in the subsequent studies, because they were so specialized to doctors that really, really were great at putting Essure in, because they had put in so many, the probability of pregnancy was only estimated to be approximately 1%. But now, years later, and seeing women 5-10 years out from Essure placement, we have found that the probability of Essure pregnancies is greater than 5 and as high as 9%. And this is 15 to 30 times higher than with traditional tubal ligation. So, unless you want to risk getting pregnant 10 years from now with a complicated pregnancy because of a failure, I would suggest that you go with traditional tubal ligation and don't even think about Essure. Or, again, the problems that we're having with Essure related to autoimmune responses are hurting women as they get older because their immune systems become more compromised. And so even though you may be very young now, who's to say in 20 years you might not start having symptoms like lupus or chronic fatigue syndrome, and it would be because of the Essure. That's my opinion.
Crystal Nicole, leaving the doctor's office after the procedure, I was in so much pain, I cried. I have been in pain on and off for 7 years now. My doctor wanted to do an ablation, but I didn't want it. A month later, he quit the practice and I moved to another state. What can I do about this pain? My new doctor doesn't know anything about Essure except what she learned at a seminar.
Okay, at a seminar is probably right. 5-hour course with 5 implantations, and there was no information given related to how to deal with the complications of the particular procedure. So my message to you is that, and this is one of the catastrophic points of Essure, the device was heavily marketed at the beginning because it was stated, especially supported by the FDA, that the procedure could be done in an office setting under local anesthetic, and that it only take about 10 minutes, maybe 15 minutes. What no one knew, well, we did, but what none of the general population knew, the women that were having it inserted, is that most doctors that were inserting Essure didn't know or were not very well skilled at hysteroscopic procedures. And so they were placing them wrong, or it was very difficult to place, or it was causing excruciating pain during the insertion. So basically, they were knocking women out in the office. Mind you that when you do a procedure like this, you're supposed to have a crash cart and be ACLS certified here in the state of Texas. But in other places, they were literally knocking women out and not really thinking about what the precautions should be. And then these women would suffer through the procedure, be it 10 minutes or more than an hour. Can you imagine having something jabbed inside of you for over an hour without any really good anesthetic? And it sounds like maybe that happened to you. And if you're having pain like that, I'm wondering whether or not the device was placed incorrectly. And if your doctor is not really well studied in Essure placement or removal, then, and I hate to have to keep saying it, you're going to have to do your homework and find someone that's that has experience in it, even if you have to travel, and because you really want to be in the best hands if you're having serious complications with it. But if the coils are properly placed, then any competent gynecologist can remove the uterus, the fallopian tubes, and the coils as a single unit, as a laparoscopic assisted vaginal hysterectomy or open procedure. As long as they don't try to cut the coils or cut through the tubes, almost all competent gynecologists can safely remove the Essure as long as it's still within the tubes and as long as it's still within the uterus.
Katie Dillon, originally when I got Essure, the doctor did not tell me it was permanent, and I'm seriously thinking about filing a lawsuit because I was not informed that I can't have it removed like an IUD. When me and my mom both asked the same question before it was placed, which was can it be taken out if I choose to have another baby, and I would just have to make an appointment with you to have it taken out, and she said yes, both questions.
Okay. Get a hold of your medical records and see what you signed off on as informed consent. If there is no informed consent that does support your position, there are statute of limitations. In each state, it's a little different. Generally speaking, it's 2 years and maybe 2.5 years, depending on where you are, from the point that you realize that there was a problem or that there was a violation of the standard of care. So if you knew just yesterday that there was an issue with it not being reversible, then the best thing to do is to talk to a malpractice attorney, explain your situation, that you were not aware that it was not reversible, and get that legal advice that you need, especially from the state that you're in.
To Neil Dotson Scott, if you have Essure, PCOS, and endometriosis, can you have the endometriosis treated, and how?
Yes. If you have endometriosis, you manage the endometriosis just like you would without Essure, but we generally recommend that you have the Essure devices removed because some of us believe that the inflammatory reaction or the inflammatory response is worsened or triggered by the Essure. And so if you're managing endometriosis, then you're going to need to, it's recommended you remove Essure. Now, for PCOS and endometriosis are generally managed the same way. So you're looking at hormone management with the use of progesterones or medications like it was suggested as the use of Lupron for 6 months. If you're thinking about trying to have another baby, then you're really going to need to speak to someone who's highly specialized in the removal of the Essure coils, but still make you able to get pregnant by a reversible Essure procedure, such as Dr. Charles Monteith in North Carolina, Chapel Hill.
I guess that would be the question that Crystal asked. I had my Essure now for 10 years, and can I get pregnant? I was 23 when I got the Essure. Now I'm 33 and want another child. That's pretty much what you're saying now.
Yes. The general studies would be get an X-ray of your pelvis or a hysterosalpingography to determine exactly how many coils you have and exactly where they're located. And then from there, from the hysterosalpingography, you can tell how far into the fallopian tube the coils are. If they're very far in, then only a highly skilled specialist can remove those coils. If they're half and half, someone that's got a significant amount of experience with Essure can do it. And if they're in what's called grade 3, then you can remove the coils more easily. But still, anybody that's looking to have a baby after Essure needs to go to a highly skilled, highly specialized doctor that removes the Essure without a significant increased risk of fragmentation, because most doctors think that it's very easy to remove. You just open up the fallopian tubes and pull the coils out, and that's where you end up fragmenting the coil, and symptoms can become even worse afterwards.
Michelle Nichols, I had Essure placed in 2012. In 2014, I was diagnosed with RA. I had Essure removed October 26 of 2017 by way of bilateral salpingectomy by Dr. Durone. My question is, when the Essure is removed, do the PET fibers come out too, or do they resolve over time? I think she meant dissolve over time.
Dissolve over time.
I'm still having a hard time with my rheumatologist getting my inflammation down.
Okay. Dr. Durone, I think, specializes in salpingotomy, which means opening the fallopian tube and simply removing the coil. It's recommended that you get an X-ray or CT scan to make sure that there are no fragments left behind when you do leave the uterus in place. My philosophy is different than a lot of my colleagues that only do salpingotomies. Imagine for a moment that you have a cotton ball attached to a piece of Velcro. Okay, you can remove the cotton ball, but there's always going to be little fibers of the cotton ball left on the Velcro. And that's my philosophy behind the idea of what's going on with the PET fibers. The PET fibers are considered permanent, and it takes, based on our studies of polyester fibers, it takes over 30 years for those PET fibers to be dissolved and absorbed by the body and no longer be present in the scar tissue that surrounds them. So, and PET fibers cannot be seen by ultrasound, a CT scan, MRI, or the HSG test done. So my impression has always been that if you take out the coils, there's still going to be little pieces of PET fibers left behind in the scar tissue that was also left behind. Now, there hasn't been any significant long-term studies to show how often that happens. But for me, I've always felt that the best way to handle the removal of Essure, and especially with patients with already established autoimmune conditions such as RA, to just have a hysterectomy, bilateral saphenectomy, and get rid of everything, take out everything out as a single unit. Treat the Essure fibers, the PET fibers, as if it was cancer. You don't want to leave any little pieces behind. Treat it like it was an infection. You don't want to leave any bit of infection behind. Take it all out when you can.
What doctor would you recommend in Texas to remove Essure and get pregnant?
You're going to need to speak to an infertility specialist. There is no one off the top of my head that I could tell you that does that particular procedure and has documented outcomes. The only one that I've seen is actually Dr. Monteith out of North Carolina, who's done over 450 procedures.
Christy, can you get artificially inseminated with the Essure?
Yes, you can. That was part of an original study that was done by infertility doctors that had problems with the fallopian tubes, which were producing something called a hydrosalpinx, which is swollen fallopian tubes. Their theory was that if you put an Essure coil inside of the fallopian tubes, the swelling comes down as the Essure coil expands, and therefore the patient had a better outcome with artificial insemination by placing through IVF and placing the embryo inside of the uterus. The problem with that is that we've had some subsequent information, and Essure has not proven to be as safe and effective as it once was thought, and there have been cases of spontaneous losses or increased risk of spontaneous loss and miscarriage with Essure placed and doing IVF therapy.
Crystal Luna, she says she's had the Essure for about 8 years now, really hasn't had any symptoms, but after hearing the negativity about it, she tried to get it removed, and the doctor told her she couldn't. She could get it removed, but it would be considered cosmetic surgery because I didn't have enough issues.
No, it's not cosmetic. It's elective. There is a difference. If you want to have a breast augmentation, that's cosmetic. If you want to have a hysterectomy, that's not cosmetic. It's elective. We don't mean to scare patients into having an unnecessary surgery, because you have to weigh the risks versus the balances. And if you fall in that 70% of women that they're doing well with Essure, then just watch your symptoms. If you start to develop something, then of course talk to your doctor about that, and maybe that will be enough to go ahead and have the devices removed. But I don't want to have women stay up sleepless nights saying this is a ticking time bomb in my body. We do want them to be aware of, look out for the particular symptoms and engage them day by day or month by month, and talk with your doctor about them, and try to find a doctor that's open-minded, because remember, we didn't have enough information about Essure when we got it approved. Now we're finding out the problems with Essure, and not enough doctors are getting that information as well, and so a lot of patients are being dismissed.
When Essure, Susan B, when the Essure is removed, the surrounding tissue should also be removed. Oh, I'm sorry, that's not. It just totally moved on me. I'm sorry, where did it go? Okay, there we go. Sorry. Melissa, I had Essure placed 10 years ago and had since then had endometriosis removal and a DNC. Can those damage Essure device or make them move?
Yes. When you have a DNC, the instruments that are placed inside of the uterus can snag the coil depending on how far in the coil is. So the recommendation is to do hysteroscopic evaluation of where the coils are. That means to put a little camera inside of the uterus, find out exactly where their coils are, and then work around the coil with the instruments to avoid snagging the coil. Now, those procedures don't necessarily make endometriosis worse, but I think that definitely, if you're going to have a DNC, that you need to have it, because DNCs are generally done blind. We place the instruments in without looking inside of the uterus exactly how far it is in or where it is, and we kind of do everything by feel. But in cases of Essure, I would recommend that you do it with a hysteroscope, place that inside, take a good look, and then there are instruments that you can place with the hysteroscope helping you to do the DNC or the modification of the curettage.
Idalia, I myself have been a victim of major back problems and just had a second back surgery. Have you been seeing or hearing a lot of Have you been seeing or hearing a lot of Essure patients having major back problems too?
Yes. Major back problems, joint problems, and teeth problems with their teeth. Women are cracking, breaking their teeth, eating normal food. They're breaking multiple teeth at the same time. I haven't seen necessarily that they've been fracturing pelvises, but the most common problems we've been seeing are with teeth, cavities that can't even be fixed. Their dentist can't get a hold of the skull properly to place even artificial teeth. Back problems are generally associated with lower back pain, which is mistaken sometimes with slip discs or inflammation of the lower back. And the source of the back problem very often is the Essure itself, causing pelvic pain, which is radiating to the back.
Cecilia, would it be possible for you to have a meeting with specialists of all kinds with the purpose to try and get specialists to raise awareness to the medical community in their area of medical field on Essure symptoms?
We actually posted a letter to our colleagues in all of the specialties advising them of the problems related to Essure. The reason that I brought up the ACOG at the beginning of the conversation is the best way to get other specialties to understand what's going on with Essure is for ACOG to do that for all of you as patients, because by informing their fellows, ACOG is also a member of other organizations of medical specialties, and those conferences can be arranged when the leaders of those particular organizations come together and are willing to talk to one another. But besides that, I've posted a letter that's generalized to all of the specialties. I'll be glad to find that if it's not already on Essure Problems Forum, and you can see the letter that we have, and we'd be glad to talk to anybody that wants to hear us. And it's not just myself, because a lot of the doctors that are specialized in this, such as Dr. Sills, Dr. McHarris, Dr. Tassone, Dr. Monteith, we are all willing to speak. We do an active discussions with patients and with other doctors about these problems.
My periods are painful and heavy. When I have a period, I have to take birth control to have a period. Can Essure cause this?
We have not seen that that Essure has stopped a woman from having a period. And the most common problems have been that they have heavy period or painful periods. But there are some women that have stopped having periods after Essure placement. We don't know the percentages. I've seen, based on the hundreds of stories that have been sent to me, that there are a small number of women that stop having periods after Essure, but we don't really understand why that's happening, unless it's a hormonal effect on the ovaries, which is putting them in a menopause or an anovulatory issues similar to a post-tubal ligation syndrome.
Amanda, hi guys. Have you seen a Dear Physician letter from Bayer yet after the FDA announcement in April?
No, I haven't. They have posted a lot of their information on their websites, but again, most doctors don't go on the internet unless it's to look up other stuff, non-doctor related stuff. So even the doctors here in El Paso that did put in Essure and were and when the guidelines came out 2 years ago, those doctors were not notified. I, as a GYN doctor, have never been notified by Bayer or a dear doctor letter from Bayer too. And mind you, there are literally hundreds of medical lists of doctors that all of this could be sent out to by a mass send out through the mail or through email addresses.
Do you recommend being part of the lawsuits?
Each case is individualized. The best person to tell you about that is going to be discussing it with an attorney. We don't favor suing someone simply because they were following the instructions that were given to them. But if your doctor did not follow the guidelines, if your doctor ignored them, if your doctor didn't get the right information to you, then yes, you should consider talking to someone about that, an attorney about that. As far as suing Bayer is concerned, there are many groups that are trying to sue Bayer directly and get the product removed off the market because it's still available here. And the only place that it's still available here is in the United States. So take home message, speak to an attorney about your concerns and follow their recommendations.
Doris, I had Essure in 2012 along with Novasure. I got sepsis and C. diff after surgery, had a uterus removed in 2013. I have liver problems, hepatic encephalopathy, major GI issues and neuropathy, fibromyalgia, and major teeth issues. It has been 5 years and I'm still not better, unable to work, quality of life is downward spiral. I was told there was no nickel that was in the surgical. I told there was no nickel, that it was surgical steel, same as heart implants. I am very allergic to nickel. Since I still have cervix and ovaries, can PET fibers still be there, and can it cause abnormal PAPs and SIN1? Okay,
it sounds like you have underlying autoimmune problems now. What we have seen is that with patients that suffer from abnormal pap smears, some of them suffer from that because of autoimmune issues. The most common cause of an abnormal pap smear is going to be the human papillomavirus. That's a possibility and need to be screened for that. Other causes are other STDs that can cause an abnormal pap smear. But of course, we fall back to the autoimmune condition. The problem that you had with the ablation and the Essure placed at the same time is exactly what we're talking about, the potential problems related to this, the synechia, the potential infection, localized but isolated infections. And it sounds like it pretty much ruined the your entire system or multiple systems. And we're very sorry to hear that, but you're not the only story that we've heard of exactly the same type of problem.
Okay, so moving on to our second part of this video.
Second part, thank you so much for everybody for being so patient. I didn't expect it to last an hour just in that part. But let's talk about now going back to our other subject. So now you have Essure. So now you've had a tubal ligation. So now you've had a hysterectomy. But your sex life has changed. And this is something that affects a significant number of women, especially with Essure, that they're having problems, that they couldn't have sex because it was so painful. And then after they have a hysterectomy, everything changes. They're not able to enjoy sex any longer. They're not able to orgasm like they were previously able to orgasm. And here's a question we often get is, what type of hysterectomy is the best hysterectomy in order to be able to still have orgasms like I did before? So this is a rated R section. So for all those ladies that are not up to it, but I think it's
just
important.
A warning.
Yeah, just a warning. But I think it's important for you to understand that this does affect not only the women for surgical cases. This is women in general. Most women don't understand that the studies that we have done, the information that we've gathered across the specialties, especially sexology, is that between 70 and 75% of all women have trouble having orgasms or are not able to orgasm frequently. And that bothers them. But they don't talk to anybody about it. They only talk to their girlfriends about it, but they don't talk to their doctors about it. And doctors are generally not in a position or feel comfortable to discuss it back, or we are just not educated enough about it either. So 10% of women, 10 to 15% of women have never had an orgasm. And so they always felt, well, it's me. There's something wrong with me. And that is not necessarily true. Most women, if they can learn more about themselves, more about their bodies, and have a willing and nurturing partner, can find or do achieve the ability to reach orgasm even before having surgery. So what the answer to the question related to, if I have a hysterectomy, what's the best type of hysterectomy to have in order to not change my sex life, to not change my ability to have an orgasm? This is keenly important on a number of fronts. The majority of women can have an orgasm simply by clitoral stimulation. There is a percentage of women that must can only have an orgasm with vaginal penetration, and then there's a significant number of women that can have orgasms either way, either through clitoral or vaginal stimulation. So when I answer or try to answer the question to my patient about having a hysterectomy, I ask her, what type of orgasm is most intense for you? Do you enjoy having a clitoral orgasm better than a vaginal orgasm? Or are both of them equal? For the women that answer that the only real way that I enjoy intercourse is through clitoral stimulation, either it's through masturbation or through my partner stimulating me through the use of vibrators or his hands, or through cunnilingus, which is oral sex, then we say, well, with clitoral orgasms, the type of hysterectomy doesn't seem to really change things too much. But for the women that have vaginal orgasms, and that's the only way that they can have an orgasm, then it does become a little bit more complicated, especially if they remove the cervix. So here we go, and you can read 1,000 commentaries on Cosmopolitan and Vogue and all of the other women magazines. Does keeping the cervix preserve sexual function and sexual intensity? And for some women it does. And the reason for that is still not really understood, but it is important to understand the concept behind why it's that way. And what we do understand is for some women, they have multiple erogenous zones, areas within the vulva and within the vagina that, if stimulated, provide significant intensity and satisfaction leading to orgasm. And so I wanted to take a few minutes to go over those particular points of the human body, the female body. And this is a good point where your husbands and boyfriends should come in and take some notes. Because even though I've done my research, I did find conflicting information even about the same subject. So, question: how many external spots are in the human body, or the human female body, are said to exist? So, hot spots, particular areas of the female body in the pelvic area, not the brain, not the mind, not the breast, the areolas. I'm talking about just in the vulva area. How many external hot spots is a woman said to have? Now, she doesn't have to have all of them, and we still don't know if they all exist. But here are the six areas that are considered to be hot spots. Now, I'm not including the clitoris, because the clitoris has its own little point of reference, because everybody knows, or everybody should know, about the clitoris. But there are 6 other areas just within the pelvic area of the female that may or may not lead to stimulation. And then once I give you that information, then we'll talk about why hysterectomy is important. The first one is going to be what's called the U spot. It is located around the urethra, so where you urinate from, around the urethra, just below and to the sides of the urethra. That is the U spot. Okay? The next spot a lot of women have heard about is going to be the G spot. The G spot, if you're lying flat on the bed, the G spot will be located on the upper portion of your vagina, approximately 2 to 3 centimeters inside of the vagina, or a couple inches within inside of the vagina, and maybe as long as 5 centimeters. So a lot of times this little area is a drop area of a firm tissue that's a little spongy, but it feels almost like about the size of a quarter that drops down into the vagina. And when you press on it, it often gives the sensation that you have to urinate. Why? Because that area stimulates just underneath the urethra, and some women do, when it's pressed or stimulated, do get the sensation that they have to pee, and then they kind of don't want to have it touched. But if you relax and get used to it, a lot of women notice that G spot, or the Grafenberg spot, or the goddess spot, is actually very, very intense stimulation, leading to a different type of orgasm than the clitoral stimulation, it's clitoral orgasm. The next one that's still on the upper portion of the vagina, or the anterior surface of the vagina, all the way to the back and just in front of the cervix, is going to be the A spot, or the anterior fornix erogenous zone, or the AFE zone. Now, it's also known as the deep spot or the second G spot. Okay, I'm going to go over these a couple times, so don't worry if you can't remember them offhand. The next spot is something that is agreed upon, not agreed upon, is controversial, is going to be the O spot. The O spot is located behind the cervix and generally difficult to reach by your hand. But it's if you press on the back of the cervix in that particular area is the O spot. The P spot is just opposite the O spot, and that's actually includes the vaginal wall, which is called the P spot, or the posterior fornix erogenous zone. And then the last one, if you had enough already with this alphabet, is going to be the K spot, or the kundali spot, which is something that's studied in Dharma philosophies of the originated in India, and in Hinduism represents the principles of cosmic order. Okay, so where is the K spot? The K spot is apparently located at the base or the tip of the coccyx, which is your tailbone, and extends downward towards the just above the anus. And this area is generally massageable. And I asked Danielle, how far would you let someone give you a massage? Would you let them go all the way down to where your tailbone is and massage you there? Because you're right there in the buttocks. And what was your answer?
No.
No. So that's basically a very intimate area. So what is the anatomy? And here we're going to go with drawings. So, believe it or not, a significant number of women have never looked at themselves in the mirror. And
Kind of hard.
And it is kind of hard. But in a mirror, I would suggest that you get yourself a really big mirror out of Walmart, one of those hand mirrors, and even one has a magnifier on the back. And understand who you are. Understand your sexuality. Don't be afraid to understand your own body, because if you don't understand your body, then nobody else is going to understand your body. Believe me, it's very difficult to understand. It's like trying to read somebody's mind. You can't do that, and no matter how long you've been with someone, you will never be able to read their mind. You may be able to think about what they're thinking, but you never really can read the mind. So this is why you need to know all the different parts of your body. And if you've got all 6 spots, that's great. If you only got a few of them, that's still good, because as long as you're having enjoyable sex, that's all that really matters. So here we go. This is a diagram of the female genitalia, as if the gynecologist or as if your partner was looking at you. So if we're looking at this, what we're looking at right here is the clitoris. Or it's about the size of a small penis, okay, the clitoris. Below the clitoris is going to be the urethra. That is where you urinate from. And the larger opening right here is the vagina, okay? So where is the U spot? The U spot is directly above the vagina and directly below or to the sides of the urethra. They are to the left and to the right, 2 little holes. They are associated with what's called the Skene glands. The Skene glands release a little bit of milky white fluid that lubricates the urethra. This area is very sensitive to pressure, so most of the time it's going to be a very light touch. Lubrication, or with oral sex, you have to be very careful. This is called the U spot, a little bit of pressure there. It is thought by some to be responsible for the significant production of fluid for women that actually have become very, very wet, or they ejaculate, and some believe that that's part of what the fluid comes from. So that is where the Skene glands are. A little bit more anatomical is this particular drawing, and what we see here is that this is now you're taking off the labia. So here you can see that is the clitoris, and it really does look like a little penis. Okay, so under normal circumstances, obviously that would be covered, but we took off the labia here. So here I've documented, if you go down from the clitoris, and here is the vagina, directly above the vagina is where you urinate from. That's the urethra. And then on each side of the urethra are the skein glands. This is the U spot. So if you were to be able to look in the mirror, here is your clitoris, here is your vagina, here is your urethra, and I put a little dot there just on one side because that is where one skein gland would be. But in this particular diagram, there is another little hole actually there, and that is the skein gland. That is where fluid comes out. So if you stimulate that particular area, that is what produces a stimulation to the U spot. And a magnification of the skein gland, real fast. This is where your urethra is. And how far does the skein gland go? It goes in pretty far, more than half an inch. And there's a little hole where the skein gland produces that fluid from. And so this area here is the vagina. So this is where the skein gland would be. That is where the U spot is. Next, I wanted to give you a drawing. Well, first we'll pull this one out. If you were to stand up straight, here's your belly button. Okay, so we're looking at your anatomy. Of course, this is how your uterus generally sits. Your fallopian tubes are up here. Your ovaries are here. The opening to your uterus is here. And this is to show you exactly how there is a space open inside of the uterus. And this is where women produce the menstrual flow and how it comes out. Women that have ablations done, when they stick the device in here, it causes all of this to fuse closed, and you can't see this opening, this gap of space any longer, and that's the problem with ablation, causing what's called synechia. Now, here's your uterus, which is shaped like an upside-down pear, and here's your cervix. Here's where it becomes key, and we're going to talk about whether or not you remove the cervix with a subtotal or total hysterectomy. And of course, this is the vagina. So, key points here: standing straight up, belly button all the way to the vagina. Why is it important to either preserve or to take the cervix? And what happens to your vagina after you remove the uterus? Does it fall out sometimes? Yes, it does. We'll talk about that in a moment. Okay?
Quick question from Angela. Do guys have a K-spot?
A K-spot?
Do guys have a K-spot?
It's supposed to be universal, so it's supposed to be for men and women. In reality, you have to really believe in massage therapy, in Hinduism, and Dharma to understand the concept of the coiled serpent, which is what it's commonly associated with, and massage therapy. But guys do have it. Guys also have a P-spot, which is supposed to be the prostate. And that's what confusion for P-spots for men and women. Okay. Okay, so now we're going to take it sideways. We're going to cut the person in half. I also have a little model here of the uterus if you want 3D, but we'll go with this chart first. Okay, so if we were to cut the person in half, and this is their lower thigh, of course this is the buttocks. Right here is the vulva. So in location-wise, if the person is standing straight up, the little circle here is where the U spot would be. The little line here is where the G spot would be. A little bit further back to where the cervix is, in front of the cervix would be the A spot. Behind the cervix would be the O spot. And in the vagina, all the way to the back, would be the P spot. Here's where the P spot is. And here is the K spot for the woman. It extends from the tip of the coccyx, or the tip of the tailbone, down to just close to the anus. Okay. Now, here's a close-up. One more time, close up. Now this is where she's standing straight up, but if she's turning sideways, here's her stomach up here. Here's the U spot. Here is the G spot. Here is the A spot. Here is the O spot. Here is the P spot. Here is the K spot. All right, so now, why is hysterectomy? How does hysterectomy affect orgasm? If you really have all of these spots, How would a hysterectomy affect you? Now, for those women that have clitoral stimulation, clitoral orgasms, because the clitoris is out here and because the skein gland is here, a clitoral orgasm and G-spot orgasm would not be expected to be affected by a hysterectomy either way, either leaving the cervix or taking the cervix, because it's so far away. So you have clitoral stimulation stays the same, U-spot stimulation stays the same, G-spot stimulation stays the same. Where it becomes interesting is what goes on right about here, because if you remove the cervix, you may very well affect your A-spot, your P-spot, and of course your O-spot is gone. So for some women that have had total hysterectomies removing the cervix, they lose vaginal orgasm ability or it's reduced. Luckily, in a significant number of women, this comes back. The nerves grow back, but it takes a little bit of time. And so our recommendation is for stimulation of the areas, even though you may not feel anything yet, give it time that it'll grow back. And of course, focus in on clitoral stimulation at the same time. Here's a very important thing for a lot of women that have vaginal orgasms. Does the size of a man really affect your ability to enjoy an orgasm? So the distance from the opening of the vagina to the cervix is generally about 3 to 4 inches. Since the average man is between 3 and 6 inches, most men can stimulate their partners, or it's enjoyable. Now, here's where we get interesting about what happens if you have a man that's larger than the length of your vagina. How is a woman able to accommodate her partner, especially if her partner's a very large partner? This is where it accommodates. Behind the cervix, in what's called the posterior cul-de-sac, which is the P-spot area, this area stretches out as far as it needs to go over time, depending on the size of the patient's partner.
That sounds painful.
Well,
it painful?
It can be. I don't know. So, if you're looking for guys that
it's pushing, it's stretching.
Yeah, it's stretching it. So, if you're looking at guys that have very large penises, we're not talking about diameters, we're talking about lengths. The distance from here to here is going to be 5 inches. So where does it go after 5 inches? When a woman with her partner over time, the penis will go behind the cervix and stretch this part out here. So whether or not he's 5, 10, or 12, whatever, it can stretch. This is how a woman can accommodate different sizes. It does become a problem, however, if you remove the cervix, because you sew all this off. And so a man that was large, it does become painful until that tissue gets stretched out again. So, but what happens for women that enjoy vaginal orgasms with large partners is that this general P area may be what gets stimulated, as well as the A area gets stimulated. So for women that have a majority of stimulation through vaginal orgasm, you may have to consider, well, what am I going to do with my cervix? Am I going to keep my cervix, or am I going to have my cervix removed? This is where, if a woman of one of my patients has a question about it, I say, we can keep the cervix. You can keep that behind and save it so that it maintains vaginal integrity. If you have any stimulation from the cervix, or if you have stimulation of the A spot, the O spot, or the P spot, that's going to be preserved. And in cases of hysterectomy, when you're removing the Essure is way up here, and so you can preserve the cervix. But when you're doing it laparoscopically, this becomes a problem. Most doctors will remove the entire uterus when they're doing a laparoscopic procedure. I generally prefer to do when I do a subtotal hysterectomy and preserve the cervix, I do it as a small C-section type of incision and preserve the cervix. But this will explain to most women that are having concerns or problems regaining that vaginal stimulation is when you remove the cervix, sometimes you may notice that there's a change in the A spot, O spot, or P spot. And mind you, if you remove the cervix, you'll probably lose the O spot stimulation in that regard. So from a frontal view, this is what's going on if you were standing straight up again. If you remove the cervix in a subtotal hysterectomy, you leave the cervix behind here. And you only remove the uterus, and you remove, of course, the fallopian tubes. And in the case of Essure, you remove the Essure coils as well. If you remove the cervix, then you're going to make an incision down here, and you're going to take the cervix. And when you take the cervix, you're going to sew up the vagina at the top, and that is going to change for some time, I'm not sure how long, the anterior and posterior cul-de-sacs, or the A-spot and the U-spot sensitivity. So here's where you're going to sew that closed. The line is a little bit further down. That's for a radical hysterectomy, where you even take more of the vagina away. And women, who undergo a radical hysterectomy, are more likely to have urinary problems as well as orgasm problems, even more so, because a portion of the even greater portion of the vagina was removed during that particular type of hysterectomy. So that is why things may change when you're having a subtotal versus a total hysterectomy. And in the majority of women, they will regain this ability to enjoy orgasm, or it actually becomes even better because it doesn't hurt anymore. There's no pain. And as long as you have an understanding partner, and as long as you understand your own body, and your partner understands your body, you're going to be able to regain or even significantly enjoy intercourse again. Now, one last comment, and this is for the patients that have suffered from Da Vinci and patients that have undergone total laparoscopic hysterectomies, is when you remove the cervix and you sew this area up at the top, okay, if you do not sew enough tissue together, if you do not put enough sutures in this top portion, this portion is going to open up, and unfortunately, all of the stuff that's up above this, which would be the intestines, are going to fall right through the vagina and out between your legs. It doesn't happen very often, but this is extremely important to discuss this with your doctor if you're doing a laparoscopic or Da Vinci robotic hysterectomy, is to make sure your doctor is sewing the vaginal cuff up very well, and also incorporating the ligaments on the side that support the vaginal cuff very, very well. One additional point is that in this particular area, inside of the vagina, when this tissue heals, it's going to leave behind what's called granulation tissue. Granulation tissue is a natural healing tissue. It is fluffy. It tends to be very friable, or it bleeds very easily. And for a woman who's suffering from post-hysterectomy bleeding 1 to 2 months out, 3 to 4 months out, or starts bleeding 6 months to a year later, it's very important that your doctor take a look and see if there's any granulation tissue that has formed in the vaginal cuff. Now, for minor granulation, it's okay to put a little bit of nitro sticks or Moncel solution to basically cauterize that with a chemical cauterization. It doesn't hurt, okay? But if it's significant, this area needs to be opened back up again from the top. Usually, you want to make sure you're not cutting into any tissue that might have scarred into here. And so this granulation tissue needs to be treated after, if it comes back 3 to 6 months or even a year later after your surgery. One other point related to hysterectomies is that a very, very common complication of hysterectomy immediately after surgery is going to be the decrease in sensitivity of your bladder. So you don't know that you have to go to the bathroom. You don't know that you have to pee. And so it's very common for nurses to pull the Foley catheter based on the instructions from the doctor. And the bladder doesn't know, the urethra is swollen up. The bladder doesn't have any nerve sensitivity. And your bladder starts to swell up bigger and bigger and bigger. If it doesn't damage the bladder, it's called transient urinary retention. And if it gets as big as 1,000 cc's, you're going to have a Foley catheter kept in there for at least 1 to 2 weeks until your bladder sensitivity comes back, and then you can remove the Foley catheter. So that's my little lecture on the different spots. Again, running down the list again, you can do your little homework, or I can post this. I'll post it on my Facebook. You're talking about, obviously, the clitoris. Everybody knows that one. The U spot, G spot, A spot, O spot, P spot, and K spot. Again, you don't have to have them all, and to be a woman, you can just have a few, or as long as you're enjoying orgasm, that's all that really matters.
Well, going back to the K-spot, you know, you asked me that question. I've gone to the chiropractor and I get massages. I do have lower back issues. If it's a female, maybe it'll be okay, as long as she doesn't go too low. But if it's a male, I probably would object to it completely. But it's not that it's for those purposes. Just, you know, sometimes they have to massage me a little lower than normal. I have to lower my pants a little bit. But other than that, that's the only reason I will let, and it would have to be a female. So
there are some great videos on YouTube for Kundali massages, but it's a very intimate type of massage that, of course, there's a lot of fun and being intimate. So obviously it would be something between you and your partner. I doubt that you really want to go unless you have very, very good confidence in the person to be stimulating the anywhere near your buttocks in the K-spot area. That takes a lot of confidence, a lot of being very open about having someone touch you there.
You know, that can be a backblast.
Yeah, be very careful when you're messing with the K-spot. Be careful,
no beans before you try that. Just kidding. There was a few questions regarding bladder prolapse after hysterectomy. Is that possible?
Yes.
And how many years out? Can it happen at any time?
My patients often ask, if I leave the cervix, what is the chance of my vagina prolapsing or my bladder prolapsing? We have seen that the possibility of a bladder or vaginal prolapse after a total hysterectomy, mind you, removing the cervix, is approximately 3% over a 10-year period of time, up to maybe as high as a 10% up to a 10-year period of time. If you leave the cervix behind, the probability of a prolapse is much lower, but you have up to a 17% chance that you may have irregular bleeding from the cervix, because here's my little model here. If you leave the cervix behind, on top of the cervix, there's still a little bit of uterine tissue left behind, and some women start to have irregular bleeding. So I go with whatever my patient desires. If she wants to keep her cervix, that's fine. I just advise her that she might have some bleeding afterwards, irregular bleeding because of the cervical tissue and uterine tissue that's still left behind. And if she wants to remove the cervix, I make sure to reinforce the vaginal cuff and the supporting ligaments, so the cardinal and uterosacral ligaments. And then I really don't. I don't really feel like there's a significant risk of a bladder or vaginal prolapse. And if it were to occur, it's going to occur over time, years or even decades later.
Pretty much they're saying that there's a whole alphabet soup in there.
Yes, there is.
If we'd be talking about cervical cancer soon in one of our shows.
Cervical cancer, yes, we'd be glad to talk about that. Obviously, we have found that over 99% of all types of cervical cancer are associated with the human papilloma virus. And the most common risks for human papilloma virus is having a partner, or having a partner that's having sex with other partners, or the person having sex with other partners. Because 60 to 80% of us will be exposed to over 100 different strains of human papilloma virus. That's a potential risk. So, take-home message, stay in a monogamous relationship, make sure that you've been checked for human papilloma virus, and generally speaking, 99% of women that are exposed to human papilloma virus will self-cure or self-suppress the virus for the rest of their life if giving approximately 2-year period of time. There are some virulent strains of human papilloma virus that lead to cancer in a much shorter period of time, but generally from time of exposure to time of cervical cancer, it can be as long as 13 years, on average longer than 2 to 10 years.
Okay. That seems like it's everything.
Okay.
So if you have any questions that you think about, we are going live every week. So gather up your questions and ask them on our next live video. I'm pretty sure I got to everyone's questions. If I didn't, I apologize. There's quite a few coming in. And I wasn't ignoring you all. I was looking at the phone, making sure I was reading everything you all were posting. So
Okay, one last time.
So we'll let
hold it for one last
since
time.
we have to go over. Someone asked, since we have to. I know.
She said, "Smell it. It smells like a new watch box." I said,
new watch smell. So since we have to go over all the shares, it's going to take some time. So give us time to go over all that, and we'll actually let you know when we'll be going live or making a video to announce the winner.
Oh, on our last giveaway, which was a fetal Doppler, the winner graciously gave the fetal Doppler back to us. So we're still offering. We could probably do it with sharing this video as well. If you want to, please share the last message we have. We're willing to give the fetal Doppler, especially to someone that doesn't have insurance, that's really concerned about high risk, or someone that's had previous losses, that would like a Doppler to be able to hear the baby's heartbeat as often as they want. There isn't any known significant risk to the use of a Doppler just to listen to the baby's heartbeat every day. Danielle does it every single day. We do ultrasounds twice a day. I hear her upstairs. I can hear bum, 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 bum. We also do ultrasounds on Danielle as often as she wants, so that she can see little Ricky. And so thank you, everybody, for all your well wishes to our pregnancy, to our son that is now.
Thank you for all the wonderful gifts too.
Yeah, the wonderful gifts. Richard is now 16 weeks.
Yes. 16 tomorrow, so 4 months.
4 months.
Yay.
Okay. And we'll be glad to answer any of your questions related to OB as well. I know we've taken a lot of time talking about Essure, but these women have been suffering for such a long time, and we really wanted to try to change things, especially since the momentum has been there. But if you have any questions related to OB, especially since there is another big catastrophe going on in OB, and that is the risk of unnecessary cesarean sections. If you have a friend who's pregnant or has been pregnant, there's approximately a 30% chance that any woman that happens to be pregnant will end up with a cesarean section, when the risk should be as low as 5%. And 50% of all cesarean sections are unnecessary. 50%. So please keep that in mind, that you don't take everything for granted, because a lot of OBs are practicing they're practicing defensive medicine, they're practicing convenience medicine, and they're not looking out for their patients. They're increasing the risk of complications. They're doing cesarean sections that are unnecessary. And if there's anybody that can answer that question better than I can, it's going to be all of those great OB nurses on every labor and delivery suite in every part of the United States. Talk to any OB nurse on any labor and delivery suite, and they will tell you how often they're seeing unnecessary cesarean sections. They can't say anything about it. They have to be quiet about it. Mum's the word, but it happens every single day in every single hospital across the United States, and it's even worse in other countries. In other countries, cesarean section rates can be as high as 80%, and they're unnecessary. So make yourself the friend of a labor and delivery nurse. They're fantastic. We want to shout out to the labor and delivery nurses at Sierra Medical Center.
Everyone's showing you their love.
The hospitals of Providence.
All the hearts that they're putting.
Hi, everybody. And some wonderful nurses I work with. Shout out to you. I know your job is very, very hard, and we greatly appreciate you. When it's Danielle's turn, we're expecting some great help from the nurses at Sierra Medical Center. All right?
Thank you, everyone.
Thank you, everybody.
Have
a good night.
Go finish the video. Right there on the bottom.